All right, encephalitis. So encephalitis is inflammation of the brain itself. So the big thing that differentiates encephalitis from meningitis is that meningitis is the meninges surrounding the brain, and encephalitis is the brain itself. And it can be a very mild case, or it could be very severe. So, inflammation of the brain itself. All right. It's caused by an infection. It can be bacterial or viral. I mean, unlike with meningitis where we know like bacteria is severe and viral's not, with encephalitis, that doesn't make a difference. And it's normally spread through mosquitoes. That's why we try to make sure we use bug spray during summer months, that we don't allow standing water, or we be careful with that because mosquitoes transfer it. And it's another big reason why we do a lot of the vaccines that we do, like MMR, varicella, because those are viruses that could cause encephalitis. Yeah. All right. So with meningitis, it's typically a kind of gradual thing because they're first have this like viral illness, right? They think they have a cold. They start having some neuro changes. They might get the nuchal rigidity and the rash, the petechiae. With encephalitis, it's not that, gradual onset. It is that sudden, like, neuro changes. So if it's mild, again, all the stuff that we've already talked about. So you could just write same, okay? Fever, malaise, headache, dizziness. Because although encephalitis and meningitis are two different disease processes, their clinical manifestations are exactly the same because of basically where it is, right? Even though one is the brain and one is the meninges surrounding the brain, they're so close that their clinical manifestations are basically the same. Severe is when they get, really sick. High fever, seizures, coma, paralysis. Okay? And again, unlike with meningitis where bacteria is really bad and viral is kind of a mild case, with encephalitis, it's just they get an infection. A virus or bacteria, it doesn't really matter. That doesn't dictate the course. And we don't really know why most people just get a mild case of encephalitis. We don't know why people get a more severe case. Maybe they're immunocompromised or their system is just set up. But again, they're just the same clinical manifestations as meningitis. So if they present like a meningitis, what do you think you're going to do? Droplet, lumbar puncture. Exactly. Good job. So they're going to do the LP. Now that comes back negative, but they're still having neuro symptoms. So now we may have to investigate a little bit more. Do a CAT scan, do an MRI, maybe get a brain biopsy, do an EEG, lab work. That will then confirm the diagnosis. But most likely their clinical manifestations, besides being the fact that it's a sudden onset versus a gradual onset, they have pretty much the same exact clinical manifestations. So we treat them, yeah.
How long are they on isolation for after starting antibiotics?
For meningitis?
For either, since they're on droplet precautions.
As soon as we rule out meningitis, droplet precautions are dropped.
But if
So,
it comes back positive.
If it comes back positive, I don't know that question. It's going to be at least 24 hours.
Well, I'm just wondering how long they stay. Yeah, I think there was a question.
Oh, is there an ATI question? I don't know the exact time. I'd have to look that up. I know with bacterial, for most bacterial infections, once you've been on antibiotics for 24 hours, you are considered not at risk, although hospitals might have policies to have them for longer periods. For a viral one, even though you've ruled out bacteria, the person still has the disease and they're just kind of running through the process. So my guess would be when they're no longer symptomatic is when they're no longer on respiratory. For encephalitis, once we do that LP and we rule out meningitis, then we take them off drop. They don't need to be on.
So the LP comes back.
Yeah, well, the LP, you won't have any protein or glucose changes. You might have white count.
Definitive test
Yeah.
for these
Yes.
go to.
Yes.
And what's the definitive test for encephalitis?
There's not really a definitive. You kind of rule it out by other things. So you're ruling out meningitis because that's more serious, and then you're treating it. You're going to get lab work done. So they'll probably know, okay, they're presenting as a meningitis. We know that encephalitis is very close to it. So we're going to test for, because it can be caused by a variety of infections. So we're going to test for the normal infections. We're going to do blood work. We're going to do, a head CT.
Right.
We may have to biopsy to get the exact organism, and then we treat appropriately. If it's viral, we treat, sometimes we can use acyclovir. If it's bacterial, then we treat with an appropriate antibiotic, which is right there. Sorry, I got ahead of myself. There you go. Symptomatic treatment, or if it's viral, we can use acyclovir. Yeah. That's a hepatic encephalitis. You will learn about that in level 4. Yeah, you can do a herpes encephalitis because it's just a virus that goes to the brain. Mm-hmm.
They already have.
Mm-hmm.
You know,
The virus. What? So. Anyone who's had a cold sore that's herpes simplex 2. There's herpes simplex. Am I confusing it? 1. I'm sorry, yes. You're right. So herpes simplex 1 is a cold sore and then 2 is general, but yes. All right. But yeah, and that's a virus, so then you would treat it. And that's what that is. HSV is that. And you would treat it with acyclovir. And then hepatic encephalopathy is a whole different thing. That, and that you'll learn about in test 4 of level 4. So you don't have to think about it right now.
Well, you don't even know what test it belongs to.
Mm-hmm.
Well, in that case, it's straight here.
All right. That's it for encephalitis. Okay? We good? I would say closer like 20. Yeah, 15, 20. Yeah. Yeah. Huh? Yeah. All right. It's good. Shh. Hydrocephalus. So what is it? It's an imbalance. So it's all about the CSF. Hydrocephalus is all about the CSF. You produce more CSF than you absorb. Okay? That's the problem. So your body produces CSF at a constant rate. So, and I'm just making up numbers here because you don't need to know that. You produce 1 ml of CSF and your body absorbs 1 ml. You produce it, it absorbs. It produces, it absorbs. What happens with hydrocephalus is your body produces 1 and then it doesn't get absorbed, or it produces 2 and the body's only absorbing 1. Does that make sense? It either produces too much and still absorbs at the same rate, or it produces its normal amount, but for whatever reason is not being absorbed. And because of that, the ventricles become dilated. And that's hydrocephalus. Yeah.
Dilation of the ventricles?
Mm-hmm. Yep. Sorry. All right. So why does it happen? That's what I just talked about. Either impaired absorption of the CSF, right? Either the body doesn't absorb it. I make my one, I'm supposed to absorb one. But for whatever reason, I don't absorb that one. Or there is an obstruction. So I make it and I can't for whatever reason.
So can you tell me more about the ventricles in the brain? Is it four ventricles?
I don't know. I don't know, to tell you the truth. I can look it up and we can talk about it after class.
Well, no, just trying to explain dilation.
Yeah. It's like a blood vessel, basically. I don't know how many there are or where they're located, but think of it as like a kind of a blood vessel in the brain. They're not, like blood vessels are kind of all over, but ventricles are just, they lead up kind of in the middle. And there's,
Aren't they like in the very center? Like
Yeah.
there's 2 of them?
I don't know how many. I can't even tell you how many. I'm sorry. But they're like, it's like a blood vessel in the fact that blood vessels carry blood, ventricles carry CSF.
Which one you mean? Obstruction to flow of CSF.
Does that help make sense?
I get migraines.
No.
How are you?
Huh?
You know, I
YouTube it?
yeah.
Okay.
I thought you said vessels, and then I looked and it said ventricles, and I didn't know there were ventricles in the brain. And I
Yeah.
was thinking like, anyway, it's fine. It's totally
I know. All right. So with clinical manifestations, the big thing you see is a rapid head growth. They have big old heads. You saw that screaming baby. They have big old heads. I don't know what happened to my picture. I have a picture of my son.
That's so mean.
I know. Oh my God, he had the biggest head. So they can have a bulging fontanelle. They have those prominent scalp veins. Are there 4?
Yes.
Okay, thank you. 4 ventricles.
And I think that just, I think ventricle just means cavity.
Yeah, it's
So it's just a,
it's just like I said. It's just like it's kind of like a blood vessel. It just holds it.
Flow in and then they come out.
Exactly. Yeah. All right. So bulging fontanelle, prominent scalp, they get irritable. Again, the lethargy, the poor feeding, the failure to fry. But the big thing is they get those big old heads. My son got his head CAT scanned twice because they thought he had hydrocephalus because he had, I should show you this picture. So when he was 2, he would run around looking like Richard Simmons because he had a big old head, this giant head. So we had to buy him all like 5 T-shirts in order to get him over his head. And then he would run around with his big giant T-shirt, his diaper, and I have a daughter that's older, and she had headbands, and he loved to wear her headbands. So he'd run around with a headband and his big old T-shirt and just run around. And I'd be like, oh, there's my little Richard Simmons. So, but they have, so we had to get his head was in the 110th percentile. And he just got a big head. He still has a big head. And then it was still high about a year later and they were still concerned. So he got CAT scanned twice because of the big head. He didn't have any of the other things, but anytime they have that big old head, they're worried about hydrocephalus. Late ones are all, it's this stuff that we've already talked about 400 times. So write it as you please. They get that high-pitched cry, vomiting, and those sunset eyes that I was telling you about. They have so much pressure in the head that they can't look up. Which one, Damaris?
Lethargy, I figured
Okay.
it out. Thank you.
Yep.
Oh, yes. How long
For hydrocephalus, it depends on what they do with them. If they're going to shunt them, yeah. Which we're going to talk about in just a second.
What's the life expectancy?
Oh, they live great. Yeah. So we'll talk about, okay, let's go to diagnosis. First thing is head circumference. They have clinical manifestations of high ICP, and then we get a CAT scan or MRI, and that shows the enlarged ventricles.
Do we need to know, like, normal head circumference?
Nope. Okay, let me see if I can go. Maybe this will help. All right. You see... normally, you see all this black right here? That's fluid. Anytime you look at a CT and you see black, that's fluid or air, okay? When you see kind of like a gray fuzzy, that's like tissue, so brain tissue. And anytime you see this white, that's bone. So here's the skull going around, and here's the gray, that's brain matter. You should not see ventricles this big. They should be like teeny tiny, like you see the black right here, how you barely see black? That's how you should see your ventricles, is barely see any. When you see like this, that's an enlarged ventricle. These are, and a lot of times we look for the little smile. So you see how enlarged they are right here? These should be nothing. You shouldn't see these at all, or just see like a little sliver of black. When they get enlarged like this, then you can see them in their big black masses. So that's how they diagnose it. So the head is large because these ventricles are large. And remember, we diagnose this early on. This is meningitis, encephalitis. You can develop those anytime in your life. Adults develop them, everybody. But hydrocephalus, this is something that you get typically at birth. Sometimes you get it acquired, but most of the time you get it at birth. And remember, their skulls are really pliable at this age still. So when their ventricles increase, their skulls kind of expand. So that's why their head circumference is so large, because that's why they have the fontanelle that's open and everything. Their skull hasn't fully formed yet and fused together, and it's not all the way hard. So that's what you're kind of looking for. Does that help visualize it better? Okay. All right. So the way we take care of it is either we remove whatever's obstructing it, but most of the time what we do is place a shunt. So if there is like a tumor that is obstructing CSF from being reabsorbed, or then we can remove the tumor and fix it that way. But most of the time we have to put a shunt in. So they take that shunt, and it's just a little tube. And they think of it, I always think of it as like an ice cream. It's or like a ball floating. It's like an ice cream scoop on top of an ice cream cone. And the shunt will, like the little ice cream or the little ball will sit on top of the ice cream. And anytime the ventricles, there's too much CSF, the CSF will make the ball float. And when the ball floats, then the fluid can drain down the shunt. But anytime it's normal, the ball's sitting on top of the shunt and it won't drain any fluid. Does that make sense? So that way, that's how the shunt controls how much to let drain based on that little ball that's kind of floating up and down. If that doesn't make sense to someone, let me know. Otherwise, so what will happen is they'll put the shunt in, and the little ball and the little ice cream cone will they'll sit in the ventricles themselves, okay? They'll sit in the ventricle, and it will, if the CSF's too much, the ball will float, fluid will drain, the ball will fall back down, it will stop draining so that we don't drain too much. They can drain it in two ways. They can drain it into the atrium of the heart to be pumped out to the body. That's less common. or they drain it into the belly. So you'll see the shunt in their head, and you'll actually see the catheter come down their neck and go in, okay? It goes down into their belly. And then it drains into the peritoneal cavity and gets reabsorbed by the body to be excreted, all right?
My patient had a IVC, whatever, the external thing was draining it.
Yes. So that is one of our biggest complications, is infection. It happens often. So what we'll do is we'll see anytime these shunt kids get an infection, we need to see them immediately. Or anytime they get a fever, we should see them immediately because they are very high risk for infection. So it's really important to teach the families about signs and symptoms. So all of those, and again, it's all about the high ICP. So everything that we've already talked about, all the signs and symptoms. Does their level of consciousness change? Do they complain of a headache? Do they have fever? Do they have malaise? Do they have vomiting? Do they have any signs and symptoms of high ICP? Because high ICP, because when it gets infected, it doesn't drain like it's supposed to. So then your CSF builds up, the pressure in your head builds up, you have signs and symptoms of high ICP. And we treat that with IV antibiotics. You'll see kids that are like, kids that are lucky, they'll come in and they're 18 years old, they had the shunt placed at birth, and this is their first infection. And then you'll see a 4-year-old, and they've had 7 infections. So I don't know why some kids get it more than others, but this is the number one risk, is infection. And so we need to teach parents signs of high ICP and fever. Those are things they need to look for, because that's going to indicate that the shunt isn't working. The other thing is that the shunt becomes obstructed. So if anything blocks the shunt, again, remember that shunt's sitting in the brain, and there's a catheter or tube that's draining either into the heart or into the belly. So I don't know, maybe the catheter gets adhered to the abdominal wall or gets kinked, or something happens where there's an obstruction, it can no longer flow. Then they have to go in and fix it, okay? So when anytime we get a patient like in the ER, they'll come in, chief complaint, headache on a shunt kid, they are triaged first, they come right back, and then we go ahead and we get what's called a shunt series done, and they get an MRI of the brain and a shunt series, and they take pictures all the way down, and then we draw labs, and that has to be done within an hour, and they want it done quick. And they image the whole thing so that they can see the shunt and the catheter and see if it's working. And then we get labs to see if they're infected so that we can start antibiotic treatment right away. We don't want to delay care for these kids. Okay. Anything about hydrocephalus?
Is there a certain antibiotic that they give, or just?
It depends on the organism itself. So, and there's too many, I wouldn't bother. Yeah, they can put it right to the shunt. Most of the time when they get infections of the shunt, they have to remove the shunt and put a new one in. But they can treat the shunt itself if it's mild.
So they have to have that little apparatus that my patient has until the infection's gone?
They can. That's one option. Because regardless, in the meantime, while they're figuring out, the first thing, they have to treat the infection. You cannot put a new shunt in until the infection's cleared, because otherwise that shunt's just going to get infected. So a lot of times they have these kind of intermediate devices because their pressure is still going to get high if we don't treat the increased fluid in their ventricles. All right, any other questions? All right, spina bifida. If you all would like me to slow down so you can see each and every slide, I can. All right. So spina bifida, it's a neural tube defect. So basically what happens is you have, I don't know if you can see in that little picture right there, you have the bone on the front. There's supposed to be bone on the back too, the spinal cord, right? So it's failure of this bony spine to close. And it can result in one of three severities. It's kind of like it's going to result in one of these three things. And in all three cases, the bone doesn't form. And there's lots of genetic and environmental factors that come into play with it. All right. So the first one is the spina bifida occulta. So there are two. So when we talk about spina bifida, there's spina bifida occulta and spina bifida cystica. Okay? There's two main types. And under this, it's going to be divided even further. Okay? So, with spina bifida occulta, you don't see anything on the outside. There's no sac. That little picture of that baby that from your slides, you don't see that. There's no sac on the outside. They just have a normal, smooth back. Most of the time they get diagnosed because they have a little dimple there or a little tuft of hair. So they'll either be diagnosed right at birth when they do their newborn exam, or they'll come into their pediatrician for their first exam, and the pediatrician should flip that baby over, spread those butt cheeks across, and look right there, and you'll see a little dimple. Like, if this is the butt, okay, right in here, right above it, is going to be a little dimple or a little tuft of hair, okay? So, now, sometimes it gets missed because they don't, it's such a, I'm sorry, not severe, it's such a mild case that they don't see anything. They don't even have a little dimple. So, sometimes they don't get diagnosed, or they get diagnosed by happenstance because they had a imaging study for something else. But for spina bifida occulta, normally there's a little dimple or tuft of hair. With the cystica, spina bifida cystica, you see something on the outside. There's a sac. If you only have meninges and spinal fluid, it is a meningocele. In cases, meninges and spinal fluid. Yeah. So with occulta, there are no neurodeficits really, because the spinal cord itself is still intact, right? There's just the bone missing to protect it. So we have to be careful. With a spina bifida cystica that has a meningocele, again, there are no neurodeficits because there is no spinal cord involvement. The spinal cord has not gone into that sac. It's just fluid in that sac. Now we want to fix it because we don't want someone to accidentally hit, because if they hit that cyst and it busts open, then you expose them to infection, and you don't want to have a spinal cord infection. And if anything gets to that spinal cord, you could have spinal cord damage. But because the meningocele does not contain any neuron elements, there is no neural defects, okay? When you have a myelomeningocele, that contains nerves. Meninges, spinal fluid, and nerves. Think of it as kind of a continuum, right? You have occulta, which is very mild, nothing on the outside, nothing to see. You have cystica meningocele that just has fluid. So no neuro defects because it doesn't contain. And then you have worst case scenario, myelomeningocele, and that contains the fluid, the nerves, the meninges, it's everything. So they have neuro deficits. Now, it might be a very mild neuro deficit. It could be a very severe neuro deficit. But they typically have some kind of neural deficits because their nerves have been exposed and they get damaged. It just depends on how much they were exposed, how damaged they get. That depends on how much deficits they have. So most of the time, we diagnose this in ultrasound. That's why moms get their ultrasounds. We can see stuff like this. This is the main source. Cystica is almost always diagnosed through an ultrasound, a prenatal ultrasound, because they can see the sac on the baby. Sometimes an occulta is missed on ultrasound, and they diagnose it afterwards by clinical manifestations. If they suspect spina bifida, or you see the sac so you know it's spina bifida, they're going to get a CT, MRI, ultrasound because they want to know the extent of involvement.
Does it ever go away?
Hmm?
Can they see it in the ultrasound, the prenatal ultrasound, and tell you that your child will have it and your child's born without it?
No.
My friend did. They told her that her son was going to have spina bifida. He was born hospital.
Okay, well then I stand corrected.
I was just wondering if it maybe can correct itself later on.
I have never heard of that, but I mean, it's medicine. I mean, anything could happen in medicine. So I guess I should never say never, but not typically. If you get diagnosed with it, you have it. Now, maybe he had a occulta, a spina bifida occulta, and I don't know. Yeah. All right. So one of the things, again, it's caused by a bunch of genetic and environmental factors. We don't really know, but one thing that has been linked to decreasing the incidence of spina bifida is folic acid. So much so that they add folic acid to most foods, like that, especially common like foods like bread. It's added to bread, different things, so that women of childbearing age have enough folic acid. And in fact, if you are trying to get pregnant or anything, they put you on folic acid. It's a big part of your prenatal vitamin. It's one of the main reasons for prenatal vitamins is the folic acid, especially those first 3 months when the spinal cord's being developed. And they've proven that since we've started introducing that, we've reduced the incidence of spina bifida greatly.
I may be jumping.
It will, I mean, it's tender to touch. You don't want to touch the myelomeningocele, you do not want to touch. Because the more you manipulate it and hurt it, yes, it's nerves, so they can feel it. And the more you manipulate it, the more damage you're going to have, the more defects they're going to have. So think of it, it's their spinal cord. So the meningocele's here at the base of their spinal cord. Everything below it's defective, okay? Or affected, I should say. Now, it could be minor. I've seen plenty of kids who had a myelomeningocele, was repaired at birth, and then they may have a little weakness in their legs, but they walk fine. You would never know unless they told you. These babies aren't delivered vaginally because they don't want to go through the birth canal, because if they try to go through the birth canal, that sac could rupture, and then they could have significant defects. So anything that manipulates that sac is going to make it worse.
Do they operate as soon as birth?
Yeah, they operate really soon. They can actually, we're going to talk about that. I'll get to that in just a second. But clinical manifestations, they have physical movement problems. They can't move their legs, right? And again, this is on a continuum. It could be very mild, where I just have a little mild weakness. Maybe I have a little unsteady gait, or they could have where they can't walk at all, that they're wheelchair bound.
At least for both types.
Yes. Well, it's mostly for myelomeningocele, but spina bifida in general is what we're talking about. With occulta, you're rarely going to have symptoms because there's no nerve involvement. And with meningocele, you typically don't have symptoms because we're mostly talking about myelomeningocele because that encases, that includes the nerves. Loss of sensation, so they can't feel hot and cold. So again, why is this important for me as the nurse? Because we're going to have to educate parents. Your baby can't feel that it's too hot or too cold, or your toddler can't feel the bath temperature, so you have to make sure you check it, before you do anything. Because they can't tell you, I'm sitting in water that's too hot, I'm sitting in water that's too cold. They may have loss of bowel or bladder. And again, it could be a very mild case where they have full control, or they may have no control whatsoever. They may have twisted or abnormal legs and feet. So they could just, again, look just like me and you, no issues. Their legs can be kind of turned in or twisted. And again, it's a severe, it exists along a continuum. So the severity could be nothing, very mild, or very severe. They have a higher risk of hydrocephalus and Chiari malformation, which is they're just at higher risk. Yeah. I can go into it if you want, but
Nope. If it's not on the test.
We got Google.
it's. I figure you guys have enough information you're getting right now.
What is the C after diagnostic? Is that C?
Clinical manifestations.
I-S.
Chiari. The H is silent.
I'm not gonna say just.
There's 2 types of Chiari malformation. They're typically in female. We can talk about it if you want. I know about that. I don't know about ventricles apparently, but I know about Chiari.
We're good.
We good, ma'am.
All right.
Management.
So, management. They can do surgery while the baby's in the belly, which is so freaking cool. I've gotten to see it once. It's awesome. So they will actually take them in before the mom is 26 weeks, or before the baby is 26 weeks. Greater than 26 weeks. Before. Greater than 26 weeks. They will actually take the mom in and open up and do the surgery, and it's really amazing. They do that because, again, the more the sac is manipulated, touched, everything, the more consequences or, worse outcomes the baby has. So if they see a myelomeningocele, they could actually take the baby while it's still in the mommy's belly and do surgery to correct it so that they have minimal complications, which is pretty awesome.
Did they do that laparoscopically or?
No, they cut the belly and they were just doing, yeah.
Have you ever seen that picture where like the baby's hand is like reaching out?
Yes, it's pretty cool. Yeah.
Wait, you gotta explain this surgery.
Well, I was just kind of in the back, so I didn't get to see it in depth. But they cut the mom open, they accessed the sac, they were in there, and then they sewed everything up. Yeah, it's pretty amazing. I don't know, I didn't get all up in there. I wasn't a neonatologist doing that, but yeah, it's pretty cool. So they can fix it in the belly, but most of the time they fix it once they're born. And again, these babies are born via C-section because we don't want to manipulate that sac too much. And it's done 12 to 18 hours after birth. So your question was, how soon do they do it? They do it right away. They make sure that the baby's stable and then they take them because, again, we don't want to ruin that sac.
How many hours?
12 to 18.
Nobody else got it.
All right. If they have hydrocephalus, they get a shunt. They have every consult under the sun. Physical therapy, occupational therapy, neurology, ortho, GU, neurosurgery. Because all of those systems are affected, right? So it is a big interdisciplinary approach to these patients. And these patients are having surgery, at 12 hours of age. They often get infections. They're in the hospital for a long time. So we have to be very careful. They're put on latex precautions early on. Because they're exposed to so much latex early on, they get put on their latex. They're at high risk for latex allergies, so they're on latex precautions. If they have, because even let's say they have a GU issue, right? They have a incontinent bladder or a neurogenic bladder. They're going to be cathing themselves all the time, so we don't want them exposing themselves to latex more and more and more and more. So we have to be very careful with them. And then most of the time, we just treat according to their level. So if they're pretty normal, then we treat them. They may have to go to physical therapy or occupational therapy to get some strength, but they can go to school and play and do it and everything. Or if they're a very severe case, then they're following up with every appropriate doctor and they're more involved. So just depending on the severity, how sick they are, that's how involved we are and how we treat them. All right. Any questions on that?
So the in utero surgery, does that have a better outcome as far as twisted leg and stuff?
That I don't know. I don't know statistics on that to tell you one way or the other if it has a better outcome. I know that I would assume that the reason they're doing it, they would put the mom at risk of that, is that they're probably thinking that if it's a bad enough case, the sooner we fix it, the less problems they have. But as far as statistics to say, I don't know that. All right. I'm going to stop it here.